Hello, everyone. It's been a while since we've had some teaching and learning in ultrasound, and this video will cover the long and short of the cervix. That is the application of ultrasound and analysis of cervix in both obstetrics and gynecological practice. Now, before we embark on understanding cervical pathology and how it looks like on ultrasound, it's important to be familiar with the normal anatomy of the cervix, and I'll do a brief recap of the same. Now, we understand the cervix, though it is a part of the uterus, is comprised primarily of collagenous tissue, and only 15% of cervix comprises of smooth muscle, unlike the uterus, which comprises of smooth muscle to the tune of 65 to 70%. We understand that the cervix is the structure between the uterus and the vagina, and it has two parts, namely the ectocervix, which protrudes into the vagina and is visible on perspeculum examination, and the endocervical part, which is better assessed by ultrasound. It is this supravaginal part of the cervix that we look for specifically on ultrasound. Now, the junction of the supravaginal part of the cervix with the uterine body has this slight external indentation, and this is the level of the isthmus of the uterus, where the supravaginal part meets the uterine body. And corresponding to the isthmus externally, we have the narrowing of the endocervical canal, which is the internal os. Now, the level of the internal os can be identified on ultrasound by seeing the uterine artery, which is seen at the level of the isthmus in the parametrium on either side. So, if we obtain a longitudinal mid-sagittal section of the uterus with the cervix, and we want to identify, especially in a gynecological patient, the location of the internal os or the level of the internal os, all that we need to do is to direct our probe laterally towards the parametrium and identify the level of the uterine artery, which would correspond to the level of the internal os. Now, the internal os connects the endocervical canal with the uterine cavity, whereas the external os, which is present at the caudal end of the endocervical canal, connects it with the vagina. Now, the endocervical canal has this fusiform shape and it tapers at both the osses, the internal and the external os. The endocervical canal is lined by a single layer of mucus secreting columnar epithelial cells. At times, this endocervical mucosa is thrown into longitudinal ridges with interdigitating branching folds, which are known as plicae palmatae, which can also be visible on ultrasound. Now, interesting thing about this endocervical mucosa is that the upper part of the endocervical canal can also undergo cyclical changes with menstruation, though to a lesser extent, like the endometrium. And therefore, occasionally you may come across a patient who has features of cystic endometrial hyperplasia, but also has similar changes extending into the upper part of the endocervical canal. Now, as compared to the endocervical canal, the ectocervix, which protrudes into the vagina, is composed of the epithelium which is seen in the vagina, and that is the stratified squamous epithelium. Now, what is interesting is this transformation zone, which is, of course, not seen on imaging, but it is the region where the glandular epithelium or the columnar epithelium of the endocervical canal is replaced by the squamous epithelium of the ectocervix. And it is this transformation zone which is the origin of cervical cancers, and that is why it is important. The interesting thing about this transformation zone is that it migrates cranially with advancing age, so that in 94% of women who are younger than 25 years of age, this transformation zone is located in the ectocervix, so it is accessible from the vagina, whereas in older women, that is, women who are postmenopausal, the location or this transformation zone is present in the endocervical canal, and hence, in only 2% of women older than 65 years of age, this transformation zone is amenable or accessible to evaluation by perspeculum examination. This proximal migration of transition zone or transformation zone is important to understand because cervical cancers in women who are in a younger age group, that is, in women whose transformation zone is more towards the ectocervix, tends to be exophytic. These cancers tend to grow into the vagina, whereas in older women who are perimenopausal and where the transformation zone has migrated cranially into the endocervical canal. The tumors are endophytic, that is, they are confined to the cervical canal, and hence they may not be visible to the naked eye on perspeculum examination and are better assessed by using transvaginal ultrasound. Now, just to give you an illustration of the transformation zone, as we discussed earlier, the part of the cervix or the ectocervix, which protrudes into the vagina, is lined by this stratified squamous epithelium, whereas the endocervical canal, this mucosa of the endocervical canal, is a single layer of columnar cells, as you see here. And it is this area where the columnar cells are replaced by stratified squamous epithelium, which is termed as the transformation zone, which tends to lie in the ectocervix in younger women who tend to have exophytic cervical cancers, whereas in women in the perimenopausal age group, the transformation zone migrates more cranially. It's located within the endocervical canal, and these women tend to have endophytic cervical tumors, which are best assessed by transvaginal ultrasound. Now, there are three types of transformation zones. Again, these cannot be seen by imaging. They've been described on colposcopy. Type 1 transformation zone is one which is completely ectocervical. As you can see here, this white area corresponds to the transformation zone. So this is completely in the ectocervix. It's fully visible, and it usually has a small or large ectocervical component. Type 2 transformation zone is where there is some endocervical component, as you see here, but the bulk of the transformation zone is again fully visible, so it can be assessed by pap smear. It can have a small or large ectocervical component, so there can be a small or a large ectocervical component of this transformation zone. Whereas this type 3 zone is one which is not fully visible to the naked eye because it has here the transformation zone is located more cranially. Now, this transformation zone has a predominant endocervical component. The ectocervical component can be small, as seen here, or it can be large. So it's just good to understand this concept of transformation zone to understand why cervical cancers look different and why we should be screening for cervical cancers using ultrasound, especially in older women. Now, again, before we understand the appearance of the abnormal cervix on ultrasound, it's important to spend some time to understand how the cervix looks normally on ultrasound. Now, please remember the best modality to assess the cervix is transvaginal ultrasound, and you will just see transvaginal ultrasound images during the course of this presentation because that is the way to go. Now, this first image shows you a longitudinal section of the cervix, as you see here. And what you can appreciate here is the presence of some anechoic contents in the cervical canal, which is nothing but the cervical mucus. One should not be worried on seeing the cervical mucus in the cervical canal. It does not suggest any abnormality. Now, outer to this cervical canal, endocervical canal, what you would see first on ultrasound is this thin echogenic layer. If you can appreciate this thin echogenic layer, this corresponds to the endocervical mucosa. Now, this is another longitudinal section of the cervix. How it differs from this image is that here there is no cervical mucus in the endocervical canal, and that is why the anterior and posterior mucosal layers are apposed, that is, they are touching each other, and that is why we see the endocervical mucosa as this echogenic stripe. So, this echogenic stripe that we see in the absence of cervical mucus is the endocervical mucosa. Now, outer to this endocervical mucosa, you can appreciate a hypoechoic band. If you see here, this hypoechoic band that you see outer to this echogenic endocervical mucosa is the fibromuscular stroma. And if you recapitulate uterine anatomy, it is quite similar to how we see the junctional zone in the uterus as a hypoechoic layer outside the endometrium. Similarly, we have this hypoechoic layer outside the echogenic endocervical mucosa, which is the fibromuscular stroma. And that is why it is hypoechoic, because it's composed of fibrous and muscular tissue. Here you can appreciate this is the entire, this hypoechoic area, this hypoechoic band that you see on either side. This corresponds to the fibromuscular stroma. So you can actually trace the fibromuscular stroma of the cervix in the anterior lip here from here to here. So this corresponds to the fibromuscular stroma in the anterior lip, whereas what you see here is the hypoechoic fibromuscular stroma in the posterior lip. Again, the hypoechoic fibromuscular stroma in the anterior lip, the hypoechoic fibromuscular stroma in the posterior lip. In addition, in the posterior lip of this cervix, you see at least two anechoic lesions. If you would switch on color Doppler, they would not show any vascularity, and these are nothing but normal innocuous Nabothian cysts or follicles, which we see often from time to time in the cervix. They can be single, they can be multiple, they can have variable size, they can appear anechoic, that is totally black, or can show some amount of echoes within them, especially when they get infected. They are totally harmless and nothing needs to be done about them unless they are symptomatic. Now, besides the fibromuscular stroma, there is another part of the cervix which is more isoechoic outside the fibromuscular stroma, and this part, which merges finally with the parametrium, is the glandular stroma. So, the cervix, starting from inside to out, we have the endocervical canal, which may or may not have mucus. Then we have the echogenic thin endocervical mucosa, followed by the hypoechoic fibromuscular stroma, which can have variable thickness from one person to another. And finally, the bulk, the isoechoic part in both the anterior and the posterior lip, this comprises the glandular stroma. Now we understand how the normal cervix looks like on ultrasound, so it makes things easier when we try to look at pathology. Now, this is an image from the literature showing you a longitudinal and a transverse section of the cervix on B mode or grayscale ultrasound. And what you can appreciate here, we'll start from inside out, is first presence of this anechoic content in the endocervical canal. So this is nothing but cervical mucus. Remember, it can be variable in amount. It may be minimal, it can be significant as you see here. Again, just the cervical mucus per se is not of any significance. Here, what the authors also appreciated was this unusual thickening of the endocervical mucosal layer and suggestion. If you see here, there appears to be folds or ridges in the endocervical mucosa, which you can appreciate even in this transverse image. So this central part is the cervical mucus. This echogenic part would be the endocervical mucosa, which is thrown into folds. And when they switched on color Doppler, there was no vascularity whatsoever, which is very reassuring. If you don't see vascularity in a cervical lesion, especially, please remember that you've lowered your PRF to as low as possible and still you do not see any vascularity. So your ultrasound machine settings should be correct. And if you don't see vascularity in a cervical lesion, it's reassuring in terms of the fact that that lesion is unlikely to be a cervical malignancy, because usually in more than 99% cases, cervical malignancies tend to be intensely vascular. So initially they thought of a cervical malignancy, but then there was no vascularity. So that took them away from the diagnosis. They also did an MRI to assess this lesion, which again did not show any contrast enhancement of this part. And these are nothing but plicae palmatae. As I told you, the endocervical mucosa, which is lined by a single layer of columnar epithelial cells, can often have longitudinal ridges, which can be unusually prominent, as you see here. I mean, they can be as prominent as these, and these are nothing but the normal endocervical ridges or the plicae palmatae, which are totally innocuous and nothing needs to be done about them. Now, coming to another lesion of the cervix. Now, what you see here is this longitudinal cervix, the section of the cervix in grayscale. Again, you see some amount of cervical mucus, which has helped because it has separated the anterior and posterior lips of the cervix. Since I scan by inverting the image, the anterior is on this side in my images. So this is the anterior and this is the posterior lip of the cervix. And you can appreciate the sessile cervical polyp, which is outlined by this endocervical mucus. I've confirmed that this is not just any debris, but something significant by the fact that you can see on par Doppler, there is a vascular pedicle going from the posterior lip of the cervix into this lesion, confirming that this is indeed arising from the posterior lip and it's a cervical polyp and nothing else. This was totally asymptomatic in this patient, and this is just an incidental finding to show you what all you can see when you start assessing the cervix transvaginally. Now, this was another patient. This patient presented with spotting and bleeding per vaginum in her pregnancy at around 10 weeks of gestation. And when we did a transvaginal scan to assess the cervix, again, besides presence of anechoic fluid in the cervical canal, we could see this isoechoic longitudinal tissue outlined by the fluid, which again, on switching on par Doppler, showed vascularity, a vascular pedicle coming from the anterior lip. So this is the anterior in my images. So this is the anterior lip, and you can appreciate the vascular pedicle going into this polyp. So again, a case of cervical polyp, which was a cause of spotting in a lady presenting at 10 weeks of gestation. There was no other subchorionic collection or anything in the uterus to explain the source, and this cervical polyp was most likely the cause of her spotting. Now, another case of cervical polyp. So far, we've been helped because there was presence of some fluid or mucus in the cervical canal, which outlined the polyp. But that is not the case every time. And here, the knowledge of the appearance of the normal cervical anatomy helps, because typically what we are looking for in a normal cervix is first a thin echogenic layer of endocervical mucosa, then an outer hypoechoic layer of the fibromuscular stroma, and then the isoechoic band of the glandular stroma. Now, if you look at this video carefully, you see something, and this is what you observe. What you can see here is presence, instead of that echogenic layer in the midline, you see this hypoechoic material distending the endocervical canal. I'll show it to you again on grayscale first. You appreciate this hypoechoic material distending the endocervical canal. If you look carefully, actually, the endocervical, the echogenic endocervical lining is here. So this is the echogenic endocervical mucosa at the top and at the bottom. And this structure that you see within the endocervical canal is actually a cervical polyp, because normally you should have seen a thin echogenic line in the center, which is not the case. It is actually displaced laterally because of this hypoechoic polyp in the endocervical canal. You can have a look at this image again. Please appreciate this hypoechoic polyp filling the entire endocervical canal. And now I've switched on color Doppler just to show you the vascular pedicle to confirm that this is actually a polyp in the cervical canal, because normal cervix does not show a vascular pedicle in the central part like this. In fact, normal cervix hardly has any vascularity, and the cervical canal has no vascularity whatsoever. So presence of this linear pedicle in the center suggests that there is a polyp in the endocervical canal. And this was again a cause of spotting in this gravid patient. You can have a look at this video again so as to assess or appreciate the hypoechoic polyp in the endocervical canal. And now you can appreciate the endocervical mucosa, this echogenic endocervical mucosa of the posterior lip and this echogenic endocervical mucosa of the anterior lip. So both have been separated because of the presence of this hypoechoic polyp within. And then you can appreciate a part of this fibromuscular hypoechoic stroma. So this is the fibromuscular stroma. And finally, this isoechoic part is the glandular stroma. So this is the glandular. So this is how knowledge of the ultrasound anatomy of a normal structure can help you suspect pathology, even if it is very subtle. And of course, as always, whenever you see something in the cervix, or maybe you can just make it as a rule of thumb that whenever you assess the cervix, do not just assess it on grayscale in two planes, but also use color Doppler so that you understand what the vascularity of the normal cervix is and are able to pick up abnormal vascularity. Now moving on, this is just to show you that this was actually the entire extent of this polyp in the cervix. So it was this big. Next, another case. Now, this was an interesting case of a lady who complained of irregular discharge per vaginum, brownish discharge per vaginum, and she was quite fed up of this problem because she'd undergone multiple scans. The endometrial cavity had been assessed. They'd not seen any endometrial polyp. I mean, they'd had a good look at the uterus, but they'd not been able to pinpoint the cause of why she, continued to have this irregular spotting. There was a report in which there was a mention of mild fluid in the cervical canal, but again, no conclusion had been drawn based on that report. Now, when I did the transvaginal ultrasound of the cervix, this is what I could see. I could see presence of this fluid definitely in the cervical canal in the mid and upper part. It had some amount of echoes, ground glass echoes, suggestive of it being blood. In addition, these echogenic foci that you see with these distal artifacts, these ring down artifacts, are nothing but just air foci, because remember, this part of the cervix can communicate with the vagina. So these were nothing but air foci. And what was interesting was that this fluid was kind of tapering or funneling over here. And beyond this, the cervical canal had a normal, or rather a narrow kind of caliber. So there was this distension of the mid and upper part of the cervical canal with this blood and air, whereas the lower part of the cervical canal and the region of the external os were apposed. And this made me think of cervical stenosis at this level, because what was actually happening was that the menstrual blood was getting pulled up at this level, and when she in the intermenstrual period, she would keep discharging this pooled blood, and that is why she was having this irregular bleeding or spotting throughout the course of her, I mean, for the last almost 2 years. And all that we suggested was that since it was a case of cervical stenosis, to do some dilatation at this level, which the patient underwent, and her symptoms were miraculously resolved. So, a simple understanding of basic dynamics can help you go a long way in making a diagnosis and treat your patient. I mean, this patient was, considering the kind of diagnosis that we gave and the treatment that she underwent, wasn't something very big. But for the patient, it was a big relief because she had been suffering from this irregular discharge for a very long period of time. Another case, just have a look at this video. This is a longitudinal section of the uterus. So what you see here is this endometrial cavity, which is again distended with ground glass echoes. So there is hematometra, or presence of blood in the endometrial cavity. In addition, you must have noticed presence of some echogenic debris in the region of the fundus and body. But what is interesting is to note that this echogenic debris had no vascularity whatsoever. So even if you lowered the PRF to as low as 0.3 kilohertz, there was no vascularity. So this was nothing but just blood clots within the cavity. And again, if you look here, the problem was actually not in the uterus, which, sometimes when you see certain things, you just keep focusing there. But the problem was again of cervical stenosis, this time at the level of the internal os. And what was happening was that the blood was getting pulled up here. You can see how there is this tapering of the blood column at the level of the internal os. And again, this was a patient with cervical stenosis. In this case, the cervical stenosis was benign because the cervix looked bang normal or absolutely normal in ultrasound. So there was no malignancy or anything in the cervix resulting in cervical stenosis. And this patient again was relieved by simple dilatation of the cervix. So whenever you see something in the uterine cavity, some fluid in the uterine cavity, or say even in the upper cervical canal, don't forget to exclude stenosis. So try to look for that tapering or that beaking of the fluid column to exclude cervical stenosis. Now, this is another case. This is a longitudinal section of the cervix, again, a transvaginal image. This anechoic structure that you see here is the minimally distended urinary bladder. And what I want to draw your attention towards is presence of this hypoechoic. It's relatively hypoechoic if you compare with this posterior lip of the cervix. This is the echogenicity of the normal cervix here. predominantly what you see here is actually the glandular stroma, whereas the entire endocervical mucosa, the fibromuscular stroma have been replaced by this hypoechoic mass, which is involving both the anterior as well as the posterior lip of the cervix. And as I said earlier, always switch on color Doppler when you're assessing the cervix. Here I switched on PAR Doppler. And what you can appreciate here is this marked vascularity, which is quite haphazard, irregular. It doesn't have a characteristic feeding vessel or anything, but quite a haphazard kind of vascularity, which is highly suggestive of neovascularization seen in cervical neoplasia. So this was a case of a cervical cancer diagnosed on ultrasound. Now, I want you to appreciate the appearance of this cervical mass and compare it with the normal cervix. So this is what a normal cervix looks like. You see the various zones, the cervical mucosa, the fibromuscular stroma, and finally the glandular stroma, along with this mild fluid in the endocervical canal. Here you don't appreciate that laminar layered structure of the cervix. Instead, you see this mass. And if you have a doubt whether there is a mass or not, just switch on Doppler. And if you see the mass light up with color, it is nothing but CA cervix for all practical purposes. Now, you can also use ultrasound if you use ultrasound beyond seeing the uterus and the ovaries to assess local invasion. So if you've seen my previous videos and know how to look at the normal bowel or the normal bladder, then you can also detect invasion into both the urinary bladder as well as the rectum posteriorly. In this case, this is again a longitudinal section of the uterus. The cervix is here. This is the fundus of the uterus. And as you can see here, the cervix has been replaced by this heterogeneous hypoechoic mass. Now, what is interesting is that this hypoechoic mass is extending posteriorly. And this structure that you see here is actually the rectum. You can identify the muscular layer, the hypoechoic muscularis of the rectum. This is the posterior muscular layer. The anterior muscular layer is seen partly here, but most of it has been invaded by this cervical mass. So you can actually assess the local invasion of cervical cancers both anteriorly into the urinary bladder as well as posteriorly into the rectum if you are aware of how their normal appearance is. And you can always go back to the previous videos on basic gynecological ultrasound to see how the normal urinary bladder and the rectum look like on ultrasound. So this is actually the invasive exophytic cervical mass invading the rectum posteriorly. Now, this is an interesting condition. It is known as adenoma malignum, and it's a malignant condition of the cervix. What makes it interesting is that patients are typically young and present with profuse vaginal discharge. So you are thinking in terms of CA cervix, but the pap smear may come out to be normal. And if you do a transvaginal ultrasound, as has been done by the authors in this case, what you can appreciate here is presence of multiple cystic lesions in the cervix. Now, don't be fooled and don't end up thinking that these are just Nabothian cysts. So a cervix with a lot of Nabothian cysts. As I said, always assess the cervix on Doppler, color Doppler. And here, when the authors switched on color Doppler, they could appreciate presence of marked vascularity in the solid areas in between these multiple cystic clusters, suggesting that they were not just Nabothian cysts, but actually adenoma malignum. This is another case from the literature showing you the classic multicystic appearance with interspersed solid areas of this entity, which you must suspect in a patient who comes with profuse watery vaginal discharge, and hence must never forget to assess the cervix on color Doppler.